clinical investigations, we all know this. I'll go into details. The only thing is, we all know this. I'll just speak a word on what is called bendopnea. Bendopnea means the patient, this is a very common symptom. Patient will complain when they actually bend down and do any activity, they'll become symptomatic. They become dyspneic. Bendopnea has three causes. Number one, decongestive phase of congestive heart failure. Number two, severe pulmonary hypertension. And number three, severe central obesity. So this is one important symptom which you should ask when you discharge the patient, that what is his symptom of bendopnea? It is decreased or that is increased. So that is why I've just shown you this clinical importance. Investigations, we all know, for intravascular congestion, simple NT-proBNP. Out of all this, I'll just mention a word of NT-proBNP. Remember, see here, out of all the trials from Paradigm HF to Galactic HF, remember, Victoria trial was the trial where the baseline NT-proBNP was the highest. That means more sicker patients. And that is why whenever you look at the results of any trial, look at the baseline NT-proBNP, number one. That's number one. And number two, you will find that if you give Versigod, and that is true for all, it's true for ARNI, it is true for SGL2, but specifically to Versigod, the decline of NT-proBNP is significant, number one, and that does translate into clinical benefits. So look at the NT-proBNP. This is an important marker of intravascular congestion, and its drop helps us in telling you that it will do that your drug is doing a good job. Tissue congestion, just a word, we all know this, Ralph's, peripheral edema and ascites. One important point. Why in congestive heart failure, ascites is at the end stage? You never get ascites at the early stage of heart failure. It's at the end, very end stage. Why? Because for ascites, the sinusoidal pressure in the liver has to be high. And what happens is in the cardiac congestion of the liver, many times the sinusoidal pressure is not that bad because we decongest the patient. Again, the pressure decreases. As against that, in portal hypertension, the sinusoidal pressure is very high. And that's why you get ascites at the early stage and peripheral edema at the end stage. It's an interesting clinical point which you all know, just to mention for tissue congestion. Investigations, we all know this, but I just mentioned a word of thoracic impedance. A word. Here, today's devices, whether it is CRTDs, ICDs, and now even in pacemakers, you have got actually the programs which will measure the impedance. The lead measures the impedance across the thorax. It's not lead impedance. It is the impedance measured by the lead across the thorax, and it gives a beep. So you get a signal which will tell the patient that okay, his volume has increased and report to a doctor. So this is one implication of the investigations, the investigation of thoracic impedance, which has now come into clinical practice routinely. Finally, one word about the clinical matters is time lag between edema and the X-ray. That means the lung edema and peripheral edema. Remember this, that many times you will find when you diurise the patient, whether IV or bolus, you will find that the peripheral edema vanishes earlier. Sometimes it's a time lag between 24 hours to 4 days for your lung RALs to go either clinically or on X-ray. And that is why you have to be careful. Many times why this is mentioned, because we tend to decrease the diuretics very fast within 24 hours once the peripheral edema goes. So until your clinical, you find that the lung, that is because that is tissue edema, it is interstitial edema. Until that decreases, your dose of diuretics should not be decreased significantly. So this is the clinical significance of lag between edema and peripheral edema and the lungs.